when a trainee starts in your practice, it really is worth treating them as if they're an infant. That it isn't normal for a child to remain as an infant, okay? And there has to be time when they're being moved on, because otherwise they're never going to get to that adult stage up here somewhere, where we all are. So the key thing is thinking about this transformation and thinking about what's important at these different stages in the life of a trainee in the scheme for registration. The challenge as a supervisor is how you can best support your trainee at these different stages in their development, both as an optometrist and going through the assessment process. Tips for success. And quality of relationship is really important. Having a structure and giving trainees, observing them and giving them feedback. So when a trainee starts in practice and going forward really, a key thing is getting to know them. One of the things we didn't talk about this morning was the other things that we check during the course of the year. And one of the things we do is that we actually ask trainees, supervisors and assessors to fill out anonymous surveys on their experience in the scheme. Now this is where you have an opportunity anonymously to dish the dirt, all right? But one of the things that never ceases to amaze me is on the questions where we're asking, you know, how did you prepare for having your trainee in practice? In those first few days, what did you do? The number of people who respond is a small proportion, fortunately, but who respond by saying they've never watched their trainee do anything. So getting to know your trainee is really important. How able they are, how confident they are, how motivated they are. That's throughout their training. And encourage high standards. You know, trainees learn more from watching and listening to you and seeing the way you manage patients than anything else. You know, you might think it's about how much you know about fitting complex contact lenses, how much you know about managing complex binocular vision cases. It isn't. It's about every day listening to the way that you communicate with your patients, the decisions you make in terms of management and how you refer them. And those are their key learnings. So, having a supervisory structure in place. Yes, it is important that, you know, trainees have learning objectives. Now, the way the scheme is set up means that, you know, a lot of this is covered for you. They know what they're aiming for. All right, but then how you kind of help them and support them is really about you having those discussions with them, thinking about how you are going to have regular meetings with them. You know, for some of them, having 10 minutes at the end of the day will be fine, and they'll learn far more from that than having a grilling session with you once a fortnight or whatever. But it's about you agreeing between you what works best for you in the context of the environment where you're working, and also in terms of, you know, the trainee's learning style, what works best for them. How are you going to deal with the queries that come up? You know, you need to agree those things in advance with the trainee. You know, the last thing you want when you're running behind on your own clinic is a trainee expecting you to give a tutorial on why you think that that's the best way of managing that patient now. All right? It may be that you just tell them what they need to do, and then you agree that you'll pick that up in your review session with them once a fortnight or whenever you do it, at the end of the day, whatever. But the key thing with this is the fact that, you know, from the beginning, this isn't about carrying them around in a papoose on your back. One of the things that John's alluded to already is this whole thing about encouraging them to stand on their own 2 feet. And that goes in this respect as well. And this is key, direct observation. Trainees say, and we know, that it improves their skills more than anything else. Watching them and giving them feedback. You can cover a lot by watching a trainee, but it's about sampling from time to time and just saying, all right, then I'm going to bob in on this patient, you stay for a little while, and then out you go. But it's really useful because it means that you're picking things up before the assessor fails them in it. And in the end, the last thing you want is that the assessor's actually brought something to your attention that you weren't aware of, and then you're wondering about the last 50 patients the trainee's seen in the last few months. So a realistic expectation when they're starting on day one is that, you know, this is where they're starting from. The aim of the game is the minimum they need to achieve is 350 eye examinations and 250 dispensings. And I would say that by the time they've completed stage 1. And they have to have completed it by stage 2. All right? And that isn't because we're reducing the numbers unrealistically. It's because that's the minimum. Hopefully they're going to see more patients than that. And all the patient episodes are compulsory. So it's worth getting that in as soon as they start, that it isn't going to be that some things, because they're more difficult to come across, or because you've just started in practice and the patient who happens to come in has got a visual field defect, or, you know, I saw a patient record that a trainee had seen on Friday, I think it was, in the stage 2 assessment, where very early on in the pre-reg training, a patient with papilledema and a marked kind of field defect, bilateral field defect, had turned up in the first sort of month or so in practice. Now that is what I call a plum patient. You know, there's so much evidence there. But equally, you know, they are going to come across these patients early on. And if the dealing with that patient is competent, they do need your support with it. And it is about them going away and reading round the subject and learning afterwards, not just thinking, I've got through that, end of, but to set them up with competent sort of practice for next time. And this whole thing about the logbook, you know, we haven't talked about that yet in terms of the setup, but it is important that they complete their logbook from day one. John's talked about that. And that they actually start contact lenses early on. Because even in visit 1, they're going to need to provide some evidence of using slit lamps and assessing tears. So the fact that they've seen contact lens patients is helpful. And at this stage, considering your appointment schedule is really, really important. Okay? Because there's going to be a lot that you're going to need to check in the beginning for you to feel confident that your trainee isn't kind of working unsafely in combination with you. Yeah? So planning their appointment schedule and yours is important. So, you know, in those first kind of weeks, you know, shadowing you is really important because they learn how you deal with patients. But quickly, you're going to be wanting to move them on. The whole point of this isn't the fact that they end up being sort of newborns for ages. Because if they're very slow in getting going, sometimes, you know, they never kind of pick it up. You know, it sort of almost means they're struggling right through the year. So having a clear goal at the beginning, this is what we're aiming for, so this is what we need to achieve early on. And you know, you're going to need to look at this with your trainee. There'll be times when they bring a record through to you and you can just look at it and feel confident because you've watched them regularly that they keep good records. And then you can look through it and think, yeah, that all makes sense. Ask them a few questions, it ties together, you're happy with that. But certainly in the beginning, you know, you're going to want to check endpoints on things and make sure the patient's acuity is what they say it is. And you are going to want to check ophthalmoscopy. And I work on the basis if they can spot things that I have to practically do a headstand to see with the direct ophthalmoscope, well then actually, I'm happy with that. Whether we're talking about visit 1 or through to visit 3, the clinical decision is often where a trainee's inexperience shows. And some of it will be down to the complexity of the patient they're dealing with. You know, and if it is a complex patient, you know, they're so overwhelmed with what's gone on and up until this point that they forget to look at the reason why the patient came in the first place and what were their presenting symptoms. And as a result, they miss key things. So just be aware of that. And that's why it's good to force their hand in terms of the clinical decision as a supervisor. All right then, so you know, this is the patient's vision and prescription. This is what you'd be wanting them to cover anyway. What did we come up with in terms of ocular health and the outcome of the investigation? What are the next steps for this patient? And have we addressed the patient's reason for visit? And throughout the supervision, whether your trainee is in those very early stages or later on, you know, they're perhaps just about to do their OSCE, all right? Next week, they're still working under your supervision, and the patient should never leave the practice without your knowledge. As a minimum, they should present that record so that you've got an opportunity to intervene. Okay? Even if all you're saying is, everything okay? Yes. Okay? Have you got any concerns about anything? No, it's all fine. Flick through, yeah, sign, and off you go. All right? And how much you go into that will depend on where they are. And that's why you need still, from time to time, to just be observing little bits so that you're confident when they're taking a history, it is a thorough history. That when they're summing up, it is thorough. That their ophthalmoscopy is covering the inferior as well as the superior cornea. And throughout their training, you know, these are the key areas you need to be considering. Embedding the code of conduct in their practice. Ensuring that they're aware that all optometrists, whether they're pre-registration trainees or qualified optometrists, are accountable. You know, they're accountable as trainees to you as their supervisor. You know, that whole thing about, it's not the ones who ask for help that you worry about, it's the ones who don't, because they're not taking the patient's welfare seriously. And you know, it's interesting that we get to stage 2 assessments and we have trainees providing us with records that don't have consent on because they're not complying with the Data Protection Act, and we can't look at them. So what if they do miss something? All right. Well, I think the key thing for us to bear in mind as supervisors is that, and as optometrists, is that we're measured against the average practitioner, all right, within our profession. Okay. And it's around whether we take reasonable action in the event that something goes belly up. Now, it won't be the first time that it has happened that an assessor could come up to you with a record. I had one once where a trainee gave me a record, and this was quite far on in their training, gave me a record to look at as a competent episode of something. And I looked at the record and I thought, might be a competent episode of that, but what about this other thing that's going on that you've obviously missed? All right. Now, in that situation, I took that record to the